Good morning, everyone. Today, we'll discuss questions related to beta blocker medications. A client with hypertension and chronic stable angina. Chronic stable angina means the myocardium is suffering from a lack of oxygen. It means the oxygen supply is less than the demand. And stable angina means there's a predictable pattern of angina. If activity increases, if the heart rate increases, if the trigger increases, if the cardiac workload increases, then angina will occur. So this is known as stable angina. So the patient suffering from hypertension and chronic stable angina is prescribed metoprolol. Whenever you see lol at the end of any drug, it means you can guess that it's a beta blocker medication. All beta blocker medications contain lol at the end, which assessment finding requires the nurse's immediate intervention. It means we have to select the condition that is very serious. Why is the beta blocker given to a patient with hypertension and stable angina? What is the beta blocker, dear? As we know, the beta blocker blocks the beta receptor. Beta blockers, which are a type of medication, block the beta receptor in the body. What are beta receptors? In our body, there are two types of beta receptors. One is found in the heart. This is the heart. And in the heart, this is the SA node, and this is the AV node, and this is the ventricular wall. In the heart, on the SA node, there's some receptors that will stimulate the SA node if sympathetic stimulation occurs, or if they get adrenaline on these receptors. So these receptors will be stimulated and will stimulate the SA node, and also located on the AV node, and also located on the wall of the ventricle. We can say that beta receptors are found in the heart. So in the heart, we name them as beta 1 receptors. And another organ is the lungs, in which the beta receptors are found. So in the bronchi, there are some receptors located in the bronchi. These are known as the beta receptors. So in this case, we will go ahead and call these particular beta receptors the so-called beta 2 receptors, just to be clear. And some of the beta 2 receptors are also located on the skeletal muscles. But the major portion of the beta 2 receptors are located in the lungs, and the beta 1 receptors are located in the heart. You can remember them by the number of the organs. Like the heart is 1 in number, it means beta 1 receptors are found in the heart, and the lungs are 2 in number. It means the beta 2 receptors are found in the lungs. Whenever there is sympathetic stimulation, or whenever the body is in a stressful condition, and so this is the kidney. And on top of the kidney, there is a gland known as the suprarenal gland. And this suprarenal gland will secrete adrenaline. And this adrenaline will reach the heart and will reach the lungs. So as this adrenaline comes and stimulates these beta 1 receptors, it means the SA node will start firing too much. It means the heart rate will increase. I am talking about the normal condition. This adrenaline will also reach the receptors on the beta receptors that are located on the AV node. Then the conduction will be faster. This adrenaline will also reach the beta 1 receptors located in the wall of the ventricles. So the heart will start pushing forcefully. It means the contraction of the ventricle will be very forceful. It means we can say the contractility will increase. So the contractility will increase, and the conduction of the electrical impulse will increase. Because the AV node helps in the conduction, the AV node helps to transmit all the impulses from the atrium to the ventricle. If there is adrenaline that reaches the beta 1 receptors located on the AV node, then the conduction will improve. So it means we can say that the conduction will also improve. That is the normal condition. And if the heart rate is increased, it means we can say that the BP will increase. If the heart rate is increased, then we can say that the blood pressure will also increase. because you can see that the formula for blood pressure is heart rate times systemic vascular resistance times cardiac output. So we can say that if the heart rate is increased, then the blood pressure will also increase. And this is the action of sympathetic stimulation, and what occurs in the heart due to the stimulation of these beta 1 receptors. We're talking about the normal condition. We haven't given the beta blocker to the patient yet. If there's sympathetic stimulation in the body, or if the body's in a stressful state, then we'll see what happens in the lungs. If the body's in a stressful state, or if sympathetic stimulation occurs, then our suprarenal gland will secrete the adrenaline hormone. That adrenaline hormone will reach the beta 2 receptors that are located in the bronchi. So after reaching the bronchi, this adrenaline will attach to these beta 2 receptors. After attaching to the beta 2 receptors, these beta 2 receptors will be stimulated. If these beta receptors are stimulated, then the smooth muscles of the bronchi will relax. So smooth muscles of these bronchi will relax. If the smooth muscles of the bronchi relax, then we can say that there is dilation of the bronchi and bronchioles, so there will be bronchodilation. If there's bronchodilation, it means we can say that the airway is open. Well, so this is the normal condition. But if these receptors are stimulated, then we can say that the heart rate will increase and the blood pressure will increase. So we will give the beta blocker. So we will block these receptors so that the heart rate won't increase, so that the blood pressure won't increase, so that the contractility won't increase, so that the conduction won't increase. So in this question, we've given the beta blocker to the patient with hypertension. So in hypertension, we want to reduce the blood pressure. So since we've given the beta blocker to the patient, it means it will block the beta receptors in the body. So as we've given the beta blockers, then we'll see that these beta blockers will attach to the beta receptors that are located in the heart. And these beta blockers will also block these receptors that are located on the AV node. These beta blockers will also block the receptors that are located in the ventricular wall. So if the beta receptor is blocked, it means if there is sympathetic stimulation, or if there is a stressful condition, or if adrenaline is coming, then it cannot bind to the beta receptors. So beta receptors will not be stimulated. If the beta receptors are not stimulated, then we can say that the SA node is not stimulated. If the SA node is not stimulated, then we can say that there will be no extra firing. So we will say that the heart rate will be reduced. So after giving the beta blocker, the heart rate will be reduced. So after giving the beta blocker, the heart rate will be reduced. If the heart rate is reduced, so we can say if the heart rate is low, then the blood pressure will also be low. That is our purpose, to give the beta blocker to the patient with hypertension. You can see that the patient is suffering from hypertension. Then we have given the beta blocker, so our purpose has been achieved. As this beta blocker has attached to the beta 1 receptors located on the SA node, so due to this, then the SA node can't fire rapidly. It means that the heart rate will be low. And as the heart rate will be low, then we know the blood pressure formula, that if the heart rate is low, then the BP will be low. So our purpose has been achieved. But we know that if in the stable angina, we are in the question. We also can see that there is stable angina is also in the patient. So what is angina? Angina is the condition in which the oxygen supply is reduced to the myocardium, but the oxygen demand is increased. So we will reduce the heart rate and we will reduce the force on the heart. So that will lead to a lower cardiac workload. So to do this, we know that as the noradrenaline reaches here on the wall of the ventricle, then the noradrenaline will not attach because these beta 2 receptors have been blocked by the beta blocker medication. If they cannot stimulate, if the adrenaline cannot stimulate these receptors, it means the heart wall will not contract strongly. If it does not contract strongly, then we can say that the contractility is also reduced. And so the cardiac workload will be reduced. And we will see that so the beta blocker also has blocked the AV node. so the AV node will transmit fewer electrical impulses from the atria to the ventricle. It means the conduction is also reduced. So these are the actions of the beta blocker here in this condition. So we have to know that all beta blockers are negative inotropic, negative chronotropic, and negative dromotropic. How can we say that? Well, all beta blockers will reduce the heart rate, and we measure the heart rate over time. So that means for time, we use another word, which is known as chrono. And these beta blockers perform an action. For any action, we use the word tropic. Because an action is occurring, it means we will use the word tropic. And we've seen that the heart rate is reduced. It means if it's reduced, for reduced, we'll use negative. And for increased, we will use positive. It means this heart rate will reduce. So we can say these are negative chronotropics. If contractility is reduced, it means the force of contraction is reduced. And for the force of contraction, we use another word which is known as ino, and an action is occurring. It means we will add the word tropic. And if contractility is reduced, it means for the reduced condition, we use the word negative. So we can say that all beta blockers are negative inotropics. Now we'll look at conduction. For conduction, we use the word dromo. And the action's occurring. It means we'll use the word tropic, and the conduction is reduced. For the reduction, we will use the word negative. It means we can say that beta blockers are negative dromopatric, negative inotropic, and negative chronotropic. So this is the action that occurs with beta blockers. Now let's look at the question. Yeah, so what is the nurse's immediate intervention? So we have to select the condition that puts the patient's life in immediate danger. The blood pressure is 104 over 68 millimeters of mercury. So we can say that the systolic is okay, but the diastolic's a little bit lower. But we're using this drug to reduce hypertension, so this is the expected effect. But if the question doesn't give any signs or symptoms of hypotension, like dizziness and cool periphery, so there's no sign of hypotension given in the question. So we can say that this is normal. This is the reading. The diastolic is slightly reduced, but this is the expected effect. So this is wrong. And another finding is a heart rate of 46 beats per minute. 46 beats per minute means the heart rate is way too low. A normal heart rate is 60 to 100 beats per minute, but this is only 46 beats per minute. This indicates bradycardia. And with bradycardia, we can say the blood pressure, if there's severe bradycardia, we can say that if the heart rate is too low, then the blood pressure will also be too low. If the blood pressure is too low, then we can say there will be severe hypotension. And following severe hypotension, the patient can go into shock. This means it's a critical condition. So the patient's life is in danger if their heart rate is 46 beats per minute. So this will be our correct answer. Mild fatigue after activity. Mild fatigue after activity can occur if the patient is taking a beta blocker, because beta blockers block sympathetic activity. And when a patient's sympathetic stimulation occurs, they have energy. But if sympathetic activity is blocked, then the patient will have less energy. So the patient can experience mild fatigue after activity. So this is expected. Respiratory rate is 18 per minute. This is a normal respiratory rate because the normal average range is 12 to 20 breaths per minute. So this is within the normal range. The nurse is teaching a client prescribed propranolol. Again, we see that it has the suffix lol. This means we can guess that this is a beta blocker drug. Which statement by the client indicates a need for further teaching? Whenever you see further teaching, it means the question is asking for the incorrect statement. So our answer will be the incorrect statement. I should check my pulse before taking the medication. Yes, in the previous question, we discussed that beta blockers are negative chronotropes. This means they will reduce the heart rate. If they reduce the heart rate in patient, so if the heart rate is reduced too much, meaning if there's severe bradycardia, then it can lead to hypotension, and hypotension can lead to shock in the patient. So before giving a beta blocker to the patient, we have to check the patient's pulse. So this is a correct statement, but the question is asking for the incorrect statement. I should not stop this medication suddenly. Yes, this is also a correct statement, because if the patient stops the medication abruptly, then rebound hypertension and tachycardia can occur. So medication should be tapered gradually, not stopped suddenly. This medication may hide signs of low blood sugar. Yes, all beta blockers can hide the signs of low blood sugar. How? First of all, I'll discuss the normal condition and what occurs during hypoglycemia, and then we'll discuss what happens after administering a beta blocker. Under normal conditions, let's say this is one of our blood vessels, and inside the blood vessel, the blood sugar level, the random blood sugar level, is very low. I'm referring to a diabetic patient. If the random blood sugar is very low, the body perceives it as a dangerous situation. Because of this danger, sympathetic stimulation occurs, and the sympathetic nervous system is activated. When sympathetic stimulation happens, our kidney has a gland called the suprarenal gland, also known as the adrenal gland, which is responsible for secreting the hormone adrenaline. This hormone helps the body respond to stress. This adrenaline then travels to the heart. It reaches the heart. And in the heart, on the SA node, the AV node, and the ventricular wall, there are certain receptors. These are known as beta receptors. Since they're in the heart, that means they are beta 1 receptors. So these are the beta 1 receptors located within the heart. Beta 1 receptors are in the heart, while beta 2 receptors are found in the lungs and skeletal muscles. Beta 2 receptors are also located there. So this adrenaline reaches the SA node. Once it reaches the SA node, it provides stimulation. It stimulates the SA node. As the SA node is stimulated, the heart rate increases. Consequently, we'll observe tachycardia in the patients. So the patient will experience palpitations and tachycardia. This serves as a warning sign of hypoglycemia. This allows the patient to recognize that they might be hypoglycemic. This means that at this point, they are able to check their blood glucose levels, which is important, and then take the proper steps to manage their condition. At the same time, this surge of adrenaline also travels through the bloodstream and reaches the skeletal muscles, which are the muscles attached to bones that help us move. And these muscles contain what are called beta 2 receptors. Stimulating these beta 2 receptors in the skeletal muscles causes tremors and handshaking. So these are the normal physiological responses. But if we give a patient a beta blocker, those beta blockers will block these receptors, specifically the beta 1 receptors. They block these beta 1 receptors and these beta 1 receptors as well. This means the same condition still exists for the diabetic patient. In a diabetic patient, the random blood sugar is low. This means sympathetic stimulation has already occurred. And due to that stimulation, adrenaline is secreted from the suprarenal gland, but this adrenaline is traveling to the heart's beta receptors. However, these beta receptors are now blocked by the beta blocker drug. So because this condition is blocked, the SA node can't increase the heart rate. That means it can't cause tachycardia. This means that even with hypoglycemia, the heart rate won't go up. There won't be any tachycardia or an increased heart rate. And so this adrenaline will also make its way to the skeletal muscles. And in those skeletal muscles, there are receptors called beta 2 receptors. And these beta 2 receptors are also blocked by the beta blocker medication. Because we've administered the beta blocker drug, this means the adrenaline can no longer stimulate these beta 2 receptors on the skeletal muscles, which means there won't be any tremors. So we can say that even if they have even with hypoglycemia in a diabetic patient, if we've given a beta blocker, there won't be tachycardia, palpitations, or tremors. This means they'll mask the signs of hypoglycemia. It's kind of like this. It's like the alarm is working fine, but we've put it on silent mode. So we could say, this medication might hide the signs of low blood sugar. That means this is a correct statement, but we're looking for the incorrect statement. So this one is wrong. I can stop taking it once my blood pressure gets better. A patient shouldn't stop their medication without talking to their doctor. So this is the incorrect statement. So that means this will be our answer here.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX Review Crash Course. The link is in the description. Now, let's continue with the topic.
A client with asthma is prescribed propranolol. Asthma? So a client with asthma is given propranolol. Again, this is a beta blocker and the patient is suffering from asthma. So which assessment finding is the most concerning? Now we have to discuss the types of beta blockers. Then we can easily solve this question. So beta blockers are drugs that block the beta receptors. And beta receptors are located in 2 parts of the body. One is in the heart. Those are called beta 1 receptors. And the other type of beta receptors are located in the lungs. So in the lungs, these receptors are known as beta 2 receptors. When we give a beta blocker medication, it blocks these receptors and has the opposite effect of what the beta receptors normally do. So now we have to think about the types of beta blockers. We can see that there are 2 types of beta blockers. But first, we'll write down all the beta blockers, then we'll classify them. So you could say that Atenolol, all drugs ending in lol are beta blockers. Atenolol, Metoprolol, Atenolol. Labetalol, Metoprolol, So these are examples of beta blockers. All of these drugs end with the suffix lol. Carvedilol. So these are examples of beta blockers. All drugs ending in lol are beta blockers. But some of these medications like Atenolol, bisoprolol, esmolol, labetalol, and metoprolol, these drugs work only on the heart. So they'll only work on the heart. Now, we know the heart has receptors known as beta 1 receptors. This means they'll only block the beta 1 receptors. So they'll work only on the heart, meaning they'll reduce heart rate, they'll reduce blood pressure, they'll reduce cardiac contractility, and they'll reduce conduction. So these are specific to the heart only. And for specific, we use the word selective. So these would be selective. And for the heart, we use the word cardio. So we can say that these particular drugs are considered to be cardioselective beta blockers specifically. So cardioselective beta blockers will only work on the heart, meaning they'll only work on the beta 1 receptors. This means they'll reduce heart rate and BP, but they won't affect the lungs. So this is a very important point. So we can say that these drugs will be safe for patients who are suffering from COPD and asthma. So these drugs will not work on the lungs. So the remaining drugs like propranolol, timolol, sotalol, and carvedilol, these drugs will work on both. It means they will work on the heart. It means if they work on the heart, it means we can say that they will work on the beta 1 receptors. If they are working on the beta receptors, so we can say they will reduce the heart rate and reduce the blood pressure. And they will also work it means these beta blockers will also work on the lungs as well. So if they work on the lungs, it means we can say that in the lungs, there are beta receptors, known as beta 2 receptors. If they work on the beta 2 receptors, it means they will block the beta 2 receptors. So normally, when the beta 2 receptors are stimulated, then so we can see that if the beta 2 receptors in the lungs are stimulated, then the smooth muscles in the bronchi and bronchioles will dilate. And if they dilate, it means the airway will open. But after giving the beta blocker, the action will be opposite to the normal condition. It means if we give the beta blocker to the patient and they block the beta 2 receptors in the lung, so we can say that beta 2 receptors in the bronchioles and bronchi will be blocked. It means there will be bronchoconstriction, and due to the bronchoconstriction, there will be bronchospasm. So in asthma and COPD patients, we should not give these medications. So they will work on both, and they will work on the lungs, and they'll work on both. And they will work specifically on the lungs. And what they do is block the beta 2 receptors. And as a result, they will cause something called bronchospasm, which means the airways in the lungs can become narrowed or constricted, making it harder to breathe. So if they cause bronchospasm, it means we can say that these drugs are not safe for COPD and asthma patients. Sometimes exams ask questions about this. So you have to remember this list that we can give this number. We can name this group of drugs like that because they work on the heart and lung. It means they're not specific to the heart. It means they're not specific to the lung. They work on both. It means they work on the heart and they work on the lungs. It means they're not specific to any organ. They'll work for both. It means they're non-specific. For specific, we use the word selective. And they're not specific to the lungs and they're not specific to the lung, but they'll work for both. It means those are the non-selective beta blockers. So you have to keep this list in mind. A lot of the time, questions are asked from this. So you have to know that Atenolol, Bisoprolol, Esmolol, Labetalol, Metoprolol, all these drugs work only on the heart. On the heart, it means in the heart there are beta 1 receptors. So they'll block the beta 1 receptors only. They won't work on the lungs. It means they won't work on the beta 2 receptors. It means there will be no bronchospasm. So we can say that all these drugs are safe for COPD and asthma patients. And these drugs work only on the heart. It means we can say these drugs are known as cardioselective beta blockers. Another group of beta blockers are propranolol, timolol, sotalol, and carvedilol. All these drugs work on both. It means they work on the heart and on the lungs. It means they're not selective. They're not specific to one organ. They are non-selective beta blockers, but there's a risk of bronchospasm, so they can't be given to patients with COPD and asthma. Now, a client with asthma is prescribed propranolol. Which assessment finding is the most concerning? It means we have to find the worsening condition that can put the patient's life in danger. Heart rate is 58 per minute. This is slightly mild bradycardia. It means this is also not good because there's bradycardia, but the next option is expiratory wheezing. Expiratory wheezing is seen in asthma. Wheezing is seen when the airway is narrow or the bronchi and bronchioles are narrowed. It means expiratory wheezing will be less. We can hear expiratory wheezing in asthma. So from both of these are not normal. Both of these are problematic conditions, but we have to apply the airway breathing and circulation rule here. So first of all, we have to prioritize the airway. This means this is a circulatory related problem and this is an airway related problem. So our answer will be this one. So we have to focus primarily on the airway. Therefore, the most concerning thing will be the expiratory wheezing option. Option C, blood pressure is 108 over 70 millimeters of mercury. The systolic is okay, and the diastolic is a little bit lower. That is expected because we are giving an antihypertensive drug. Fatigue is expected if we are giving a beta blocker because beta blocker drugs reduce sympathetic nervous system activity. So the patient will have less energy and be less energetic, meaning fatigue. Fatigue can be seen. The nurse is caring for a client receiving Atenolol. Again, this drug ends in lol, which means it's a beta blocker. Which laboratory value is most important to monitor in a diabetic client? So the patient is diabetic. So whenever we are giving a beta blocker to a diabetic patient, we have to keep in mind that the beta blocker will mask the signs or symptoms of the diabetic patient. So the beta blocker will mask the signs. So beta blockers will mask the characteristics of hypoglycemia in a diabetic patient. So we have to check the blood glucose if the diabetic patient is taking a beta blocker. Hemoglobin, no need to check. Potassium, no need to check. A client receiving carvedilol for heart failure develops dizziness when standing. What is the nurse's priority action? It means carvedilol. It means we can say this is a beta blocker. And we saw the list in the previous question that carvedilol falls under non-selective beta blockers, meaning it will work on both the lungs and the heart. Also, the patient has developed dizziness. Dizziness means there may be reduced cerebral perfusion. So because of this, the patient has developed dizziness when standing. This means we can say there is orthostatic hypotension when the patient sits up from a lying position, or when the patient stands up from a sitting position. If dizziness is seen, then we can say the patient has orthostatic hypotension, and this is commonly seen with antihypertensive drugs. This occurs because when the patient sits up from a lying position, or when the patient stands up from a sitting position, our blood will go toward the lower part of the body, toward the legs, due to gravity. This means less blood will enter the lungs. It means there's less blood, so the heart has less blood to pump. This means less blood will reach the brain. It means cerebral perfusion is reduced. And so two factors will combine. First, the antihypertensive drug is also lowering the blood pressure. Second, gravity is pulling the blood toward the lower part of the body. So these two factors combine and there's a chance of orthostatic hypotension. And how do you assess orthostatic hypotension? To check for orthostatic hypotension, the nurse must check the blood pressure while the patient is supine or lying down. After that, the nurse has to check the patient's blood pressure in a sitting position. And after that, the nurse has to check the blood pressure in a standing position. If the nurse notes a significant drop in blood pressure from supine to standing, it means there's a chance of orthostatic hypotension in the patient. So now we'll see. A patient receiving carvedilol for heart failure develops dizziness. That means dizziness. When standing, it means there's orthostatic hypotension. What is the nurse's priority action? So we have to prevent the patient from falling. So discontinue the medication immediately. If we stop the medication immediately, there will be rebound hypertension or rebound tachycardia. So we should not discontinue the medication. Encourage slow position changes. Yes, we have to ask the patient to change position slowly. This is the correct answer. Increase sodium intake. The patient is suffering from hypertension or heart failure. If the patient has heart failure, then giving sodium, so increasing sodium, will also worsen the heart failure condition. So this is also wrong. Administer the medication with an antacid. This is not related to treating the dizziness. The nurse is reviewing a client's history before administering the Metoprolol. LOL. It means this is a beta blocker, and beta blockers are categorized into two categories. The first ones work on the heart. That means they are cardioselective. So Metoprolol falls under the cardioselective beta blockers. And the second category is non-selective. Non-selective beta blockers work on the lungs as well, meaning they will cause bronchospasm in the patient. So for which client should the nurse question the prescription? Meaning to which client can we not give Metoprolol, or to which client can we not give a beta blocker? A client with hypertension? For hypertension, we give beta blockers because beta blockers reduce blood pressure. So this is incorrect because the question asks for the client to whom we can't give it. Beta blocker, a client with chronic stable angina. Angina, as in angina pectoris. Angina pectoris means oxygen demand in the heart is increased, but supply is reduced, leading to chest pain. That is called angina. It's called stable because the pattern is predictable. If exercise increases, if the patient runs, jumps, or if the oxygen demand is increased due to certain factors, then angina pectoris will occur. And as oxygen demand is reduced or supply is increased, or if the patient rests, or the trigger is removed, or nitroglycerin is given, then the angina pectoris will subside. Meaning, so we can say that is stable angina. So beta blockers reduce the heart rate, meaning the heart has to slow down. So the heart rate will slow down, and beta blockers also reduce the force of contraction. This means the heart doesn't have to work as hard. So the cardiac workload will be reduced. That means the demand for oxygen will decrease. So we can give beta blockers in this condition. The question is asking which condition we cannot give it in. So this option is incorrect. A client with a second-degree AV block. So we need to look at what a heart block actually is. This is our heart, and this right here is the SA node. And that SA node produces the electrical impulse or electrical signal. That electrical signal then spreads over the atria. Then these electrical signals transmit to the ventricle via this AV node. And let's say, for example, suppose there are 10 electrical impulses, and all 10 of those impulses reach the ventricle. That means we can say the conduction is fine, but if there's a problem and only 5 out of 10 impulses reach, it means the conduction system isn't working properly. It means the AV node is not working properly. So there are 3 types of heart blocks. First, let's suppose that electrical impulses are being generated and all of them reach the ventricle via the AV node. So what this means is that if you have, for example, 10 electrons, just as an example, I'm simply using these particular numbers here to help you better understand the concept. So suppose 10 electrical impulses are generated by the SA node or are in the atrium. Then all 10 will reach the ventricle, but they will reach it slower than normal. So they reach slower. This means we can call this a first-degree heart block. First degree heart block, which is a problem with the heart's electrical system, can affect how the heart beats. So we'll call this a first-degree heart block. But in another condition, let's say, for example, that there are 10 impulses, specifically 10 separate electrical impulses occurring in the atria, all happening within a short period of time. But out of 10, only 8 or only 9 are reaching the ventricle. This means that the impulse is missing. So we can say the electrical signals are missing. So this is what is known as a second-degree heart block. Basically, it's called a second-degree heart block because there is a delay or interruption in the electrical signals that travel through the heart. Suppose, for example, that if a total of 10 electrical impulses are generated in the atrium by the sinoatrial or SA node, but out of those 10 impulses, not a single one of these electrical signals actually manages to reach the ventricle. In this case, it means that this particular situation will be referred to as what is known as a third-degree heart block, which is also sometimes called a complete heart block. So this is the heart block. But suppose that if we give a beta blocker to the patient, the beta blocker will attach to the AV node. The beta blocker will attach to the beta receptors. These are the beta 1 receptors on the AV node. If we give the beta blocker to the patient, then the beta blocker will attach and block these beta 1 receptors. If these beta 1 receptors in the AV node are blocked, it means the electrical impulses that are over the atria will not reach the ventricle, or they will reach slower, or they will reach in fewer numbers. It means the heart block condition will worsen if we give the beta blocker to a patient who already has a heart block. Because in heart block, the AV node transmits fewer electrical impulses from the atria to the ventricle, or the AV node is reducing, or the AV node is sending fewer, or the AV node is sending slower electrical impulses to the ventricle, or the AV node is not sending or transmitting the electrical impulse from the atria to the ventricle. And then we give the beta blocker, they will block. So this condition will be a very worsened condition. So in the heart block condition, we should not give it. Suppose that if the patient is suffering from first-degree heart block, in first-degree heart block, the impulses from the atria reach the ventricle via the AV node, but they reach slower than normal. But if we give the beta blocker, it means that first-degree heart block can change into second-degree heart block. The AV node is working less. But if you give the beta blocker, then it will work very, very little. And then some electrical impulses will not reach the ventricle. It means the heart block condition will be worsened if we give the beta blocker to the patient. So the question is asking for the condition in which we cannot give the beta blocker. So a client with a second-degree heart block. This means we should not give the beta blocker to a patient suffering from a second-degree heart block. A client with a history of myocardial infarction. Myocardial infarction is a condition where the tissue in the myocardium is damaged due to a lack of oxygen. We want to reduce the workload on the heart's myocardium. If we want to reduce the workload on the myocardium, then we have to slow down the heart. This means we have to reduce the heart rate in the patient. So to reduce the heart rate and blood pressure, we can give the beta blocker. It means we can give it. So this will be the wrong answer. A nurse is monitoring a client after the first dose of labetalol. Labetalol, again, is a beta blocker, and labetalol is a cardioselective beta blocker because it works only on the heart. Which finding requires immediate action? This means we have to find a serious condition after giving labetalol. A heart rate of 62 beats per minute? That is normal because the normal heart rate is 60 to 100 beats per minute. So this is incorrect. Blood pressure of 88 over 54 millimeters of mercury with dizziness. And so first of all, we can see the reading is abnormal. So it means there is hypotension, and there is a characteristic of hypotension, dizziness. This means there is severe hypotension. If there is severe hypotension due to the beta blocker, it means it can lead to shock. So this requires immediate intervention. So this is the correct answer. Fatigue. Fatigue can occur if the patient has taken a beta blocker because beta blockers reduce sympathetic stimulation in the patient. So this is wrong. The nurse understands that beta blockers decrease blood pressure primarily by the question is asking how the beta blocker reduces blood pressure in the patient. Increasing sodium excretion? No, sodium excretion is not done by the beta blocker. It is mostly done by some diuretics. So this is wrong. Blocking calcium entry into the cardiac cells? No, this is mostly done by CCBs or calcium channel blocker drugs. Reducing the heart rate and the cardiac output? Yeah, beta blockers reduce heart rate and cardiac output by blocking the SA node, the AV node, and the beta 1 receptors on the myocardium of the ventricle. So this is the correct answer. Dilating the coronary arteries directly? No, this beta blocker does not directly dilate the coronary artery. A client taking propranolol reports sweating. Sweating, confusion, and shakiness. Which action should the nurse take first? Sweating, confusion, and shakiness. There could be hypoglycemia in the patient. And the patient has also taken the beta blocker. This means propranolol is also being given to the patient. So what is the nurse's next action? Administer the next beta blocker dose. If we administer the next beta blocker dose, then the condition will worsen because the beta blocker masks hypoglycemia in the patient. That means this is wrong. Check the blood glucose. Yes, if the patient is taking propranolol or any kind of beta blocker, and if the patient is sweating, then we can say there's a chance of hypoglycemia. There's no tachycardia and no palpitations because the beta blocker has blocked the SA node. Because of this, the SA node cannot generate an excessive heart rate. This means tachycardia won't occur despite the patient having hypoglycemia. So check the blood glucose. Place the client flat in bed. This won't reduce the hypoglycemia. Restrict the fluid intake. This won't reduce the hypoglycemia. A client with heart failure is prescribed bisoprolol. Bisoprolol. It's also a beta blocker, and it's a cardioselective beta blocker. That means it'll work on the heart only, not on the lungs. Which statement by the nurse is most accurate? This means we have to select the correct statement regarding bisoprolol. This medication increases the heart's workload. Now, all beta blockers reduce the workload. So this is incorrect. This medication cures heart failure permanently. No, this doesn't cure the heart failure permanently. This drug should be stopped if the pulse falls below 100 beats per minute. If we're getting a beta blocker, then the beta blocker should be withheld if the heart rate is below 60. That means if there's bradycardia or the heart rate is below 60, then we have to stop the medication. We have to stop the beta blocker. But here the heart rate is 60 beats per minute. This is normal. So this is also wrong. The medication may initially worsen fatigue before improvement occurs. Yes, if we give a beta blocker to the patient, then initially fatigue can worsen because the patient can feel excessive fatigue. You know that if you give a beta blocker to the patient, then the beta blocker suppresses or reduces sympathetic stimulation in the patient. Since this sympathetic system is suppressed due to the beta blocker, there will be less energy. That means the patient can feel excessive fatigue. So this will be the correct answer. The nurse is reviewing prescriptions for beta blocker therapy. Which client is the most appropriate candidate to safely receive a beta blocker? This means we have to select the answer where we can safely administer the beta blocker. And we have to eliminate all the options where we cannot safely give the beta blocker. If we give the beta blocker to these patients, then there could be some kind of complication. So a client with asthma and expiratory wheezing. If the patient has expiratory wheezing, it means we have to avoid beta blockers, especially those that affect the lungs. This means there are two types of beta blockers. One works on the heart, it's called cardioselective. And examples of cardioselective ones are Atenolol, Bisoprolol, Esmolol, and Labetalol. So these will work on the heart only. But other drugs, other beta blockers, work on the lungs as well. That means they work on both, on the lungs and on the heart. This means we should avoid non-selective beta blockers in patients with asthma. Non-selective beta blockers include propranolol, timolol, and sotalol. So these drugs should be avoided in patients with asthma and wheezing. So this is incorrect. A client with second-degree AV block and bradycardia. Yes, we cannot give beta blockers to a patient suffering from second-degree heart block or bradycardia because we know that beta blockers are negative chronotropes. This means they'll reduce the heart rate by blocking the beta receptors on the SA node. This means they will worsen the bradycardia. So we can't give them to a patient suffering from severe bradycardia and second-degree heart block. So in the second, what do you mean by second-degree heart block? It means the electrical signals from the atria are reaching the ventricle in fewer numbers due to the problem in the AV block. It's due to a problem in the AV node in the heart. If we give a beta blocker to the patient, then the AV node, the beta receptors on the AV node are blocked by the beta blocker. This means that the conduction will be reduced. If conduction is reduced and it's already low, it means the condition will worsen. So we can't safely give it to this patient, a client with acute decompensated heart failure and pulmonary edema. Now, we can give beta blockers to stable heart failure patients, and in those stable patients, it's to reduce the cardiac workload. But in acute decompensated heart failure, we can't give beta blockers because they reduce the force of contraction. This means blood won't be pushed effectively or pumped out from the ventricle. And acute decompensated heart failure means the heart still isn't pumping blood effectively, so blood pools in the ventricle, the atrium, and the lungs. This means crackles and dyspnea are also present in the patient. So in this condition, if we give a beta blocker, well, we know how beta blockers work. So beta receptors are also in the myocardium in the ventricular wall. This means the ventricle won't contract effectively. If the ventricle doesn't contract forcefully, then less blood is pumped from the heart. So for acute decompensated heart failure, beta blockers are contraindicated. A client with chronic stable angina and hypertension. Yes, for hypertension, we can give beta blockers to lower blood pressure, and for chronic stable angina, oxygen demand in the myocardium is increased while the supply is reduced. That's what leads to angina pectoris. But we'll reduce oxygen demand by lowering the heart rate and reducing the force of ventricular contraction. So we can give it to the patient. We can give beta blockers to a patient suffering from chronic stable angina and hypertension. The nurse is caring for a client with COPD and expiratory wheezing. This means the patient has COPD and expiratory wheezing. It means there's a bronchospasm in the patient. Which beta blocker prescription does the nurse anticipate the provider will prescribe? This means we must select the medication we can give to a patient with COPD and expiratory wheezing. So propranolol. Now, we have to keep in mind that there are two types of beta blockers. One is cardioselective. Cardioselective works only on the heart to reduce heart rate and blood pressure. The other is non-selective, a non-selective beta blocker. Non-selective beta blockers will work on both. This means they'll work on the heart and they'll work on the lungs. So, a non-selective beta blocker will reduce the heart rate in the heart, but will also lead to bronchospasm in the patient. But cardioselective drugs will only lower the heart rate and reduce blood pressure, but they won't have an effect on the lungs. So we can safely administer beta blockers that are cardioselective. Because of that, we must keep in mind which specific drugs are cardioselective. So here's the list of cardioselective drugs. Atenolol, bisoprolol, esmolol, sorry about that, esmolol again, just to be clear, labetalol, metoprolol. These are the cardioselective drugs, so we can give them to patients with COPD and expiratory wheezing who need beta blockers for hypertension. However, non-selective drugs affect both the heart and the lungs. Examples of these non-selective beta blockers include propranolol, timolol, and sotalol. Now, we need to solve this. And nadolol is also a non-selective drug. Nadolol. So propranolol falls under the non-selective category. This means it will cause bronchospasms, which means we cannot give this. Nadolol is also a non-selective beta blocker, meaning it will cause bronchospasms, so we cannot give it. Metoprolol is a cardioselective drug. This means it will lower the heart rate and BP, but it won't worsen the COPD and expiratory wheezing. So we can give this. Timolol is a non-selective beta blocker. It'll reduce the heart rate and BP, but it'll also cause bronchospasms. Therefore, we cannot give it to patients suffering from COPD, and expiratory wheezing. So those were the beta blocker drugs. We'll see you tomorrow in the next lecture. Thank you.